notification should pop up on your screen. Okay, great. So last month, the Department of Human Services, along with the Oregon Health Authority, published a summary document of the interim guidelines for COVID-19 and other respiratory pathogens that we're seeing circulate through this respiratory season. And this summary document was not meant to be an exhaustive list of all the guidelines for these settings, but is meant to be used as a general at-a-glance guide for staff within long-term care settings. And so, as with any guidance document, we certainly understand that there's often confusion surrounding certain guidance points, and we wanted to reserve this hour to provide some clarifying information and leave time for questions that may not be covered within the document itself. So today I'm joined by Dr. Rebecca Pierce, who is the manager for the Healthcare Associated Infections Program at the Oregon Health Authority. And I'm also joined by Jack Honey, who is the manager of the Safety Oversight and Quality Unit here within DHS Aging and People with Disabilities. Becca's going to go ahead and give us some information surrounding some of the frequently asked questions that we've received about this particular guidance. But before we move into Becca's updates, we'll go ahead and hear from Jack, if Jack's hopped on, to give a brief update from the SOQ team as it relates to this guidance. And I think it'll be really helpful for you all.
Thank you, Bailey. Can you hear me?
Yes.
All right. Yeah, good. So just very briefly, first of all, thank you everyone for joining us. And I wanted to give a special thanks to Bailey and Dr. Pierce for the work they've done along with us at SOQ on this guidance. Hopefully it will go a long way towards addressing some of the questions and confusion that you've had, especially around the frequent multiple changes to guidance and recommendations with COVID. Before we go into the actual guide, and before I hand it over to Dr. Pierce, I just wanted to address one thing. The biggest question that we get, or most frequent question, is around the language recommendation versus requirement. Or as it's put in the guidance, sometimes it says should as opposed to must. And this is true both for this guidance that we have developed as well as with CDC and CMS guidelines. So the thing to keep in mind is what we are going to be looking for, we meaning the survey teams when we come into the facilities, is kind of an overall or holistic approach in your facility to infection control and safety practices related to the spread or the control of the spread of COVID-19. So if there is something that says should in the guidance, that means that this is probably a best practice or a recommendation from CDC. It may be something that you can easily implement, and we would like to see that you are attempting to do that. It may be something that based on your resident mix or your physical plant, there are different challenges to implementing some of these recommendations. And as long as it doesn't say must or required, then you're okay with recommendations. What we will look at then is, again, the whole big picture. If something is recommended to prevent the spread of COVID-19, we're going to be looking at, why you're not able to implement it and what else you're doing to mitigate that risk. So, for example, if you've got an area that's too small for some of the spacing, so then we're going to look at, well, how have you considered the intent behind the recommendation, and how are you ensuring that people are safe? So that's really it. Now, if something is, of course, required by the guidance, we're going to be looking to ensure that you are implementing it. Something that's recommended, again, we're going to look at your entire approach, your holistic approach, and work with you on that. Now, one thing that I will say, and I always say this, is please feel free to contact me or the program manager or your OPA, the operations and policy analyst that you work with, especially if there are recommendations in the guidance that you aren't implementing, that you aren't sure about. Now, you're not required to contact us if you're not implementing every recommendation, but if you're unsure and you want to walk through it, let us know what you are doing, what your different ideas are. We're more than happy to talk that through with you before survey shows up. and can explore some of the options, and more than happy to make sure that you've got appropriate infection control implemented before we come out. So hopefully that helps as we go through the guide now.
Yes, thank you so much, Jack. And before we move on, are there any just kind of glaring questions for Jack, or any points of clarification that we need to address before moving into the technical guidance? And please feel free to put it in the chat. That's what I am monitoring.
Thanks, everyone. And I will be here through this meeting, and I'll jot down any questions or concerns that do come up. If we're not able to answer them immediately, I'll bring it back to the team and we will get back to you.
Great. Thank you so much, Jack.
Yeah, thank you.
Yeah. So we'll go ahead and move into Dr. Pierce's presentation. And again, if at any time there's something that comes up that you'd like to address within this meeting, feel free to put in the chat. We do hope to leave a little bit sometime towards the end of the meeting for more open-ended questions. So with that, I'll pass it over to you, Dr. Pierce.
Thanks, and hi all. Happy snowy Friday if you're in the Portland metro. My name is Becca Pierce. I've worked with Bailey and Jack for a long time, and all of you for quite a few years now, but I manage the healthcare associated infections programs at Oregon Health Authority, and I lead our infection prevention work alongside our infection prevention team. I have a lot of good questions that have come in through a number of different routes, both to our team, Bailey's team, OPA's. So we've kind of pulled them all together. There was a lot of common themes. So I'm going to go through those pretty informally and just answer them in sort of Q&A format. I'm really going to try and stick to 25 minutes or so, just so we make sure we have time to open it up to all of you. And we will start there. So I'm just going to leap in. The first question that we got quite a bit was about the 6-foot physical distancing. So this particularly worded one, which I think was a helpful example of what we saw quite a bit, was, is 6-foot distancing between tables required in dining during an outbreak? Is the answer different when there is not an outbreak? So when there's not an outbreak in a facility, there's no specific requirements about the 6-foot guidance. It's really been de-emphasized in more recent guidance. It's still referenced in CMS guidance in relation to visitation. But the reason it's been de-emphasized is really because COVID-19, SARS-CoV-2, the organism that causes COVID-19, is really able to spread a bit further in the air. It can spread via aerosol transmission. So though that 6-foot demarcation is helpful in the sense that it can be used as a tool to reduce crowding, which is still super meaningful as an infection prevention strategy, really focusing on exactly 6 feet maybe isn't always our focus anymore. So just to keep in mind that we have a lot of facilities that are still using 6 feet. That's just the way they're implementing a strategy so that they don't have too many people in a room at once. That is still totally reasonable, and it's something we like to see when we're out in the field. There are a number of other strategies around dining, like staggering meal times where that's available, trying to limit the number of residents per table. There's also more kind of engineering level controls that can be implemented. Dining is always tricky. It's tricky both for break rooms, for staff, as well as for residents, because of course people really can't mask and they're talking and there's potentially some close contact, but important close contact that's important for quality of life. So if we're looking to sort of reduce the risk more generally of those scenarios, things like improving ventilation, so having portable HEPA filters or things like that in dining areas can really help. And even simple things like when our weather is a little bit better, being able to open the windows, maybe turn up the heat to adjust and allow some better ventilation in the room. Those can be really important. So long story short, physical distancing has been de-emphasized a little bit. It's still a potentially important tool, and reducing crowding to kind of avoid those super spreading events is still a super important thing to be considering in your facility. Similar question about plexiglass dividers. Are there any dining restrictions like plexiglass dividers still in place because of outbreak status? So again, because COVID-19 can spread via smaller droplets and aerosols, which could spread over larger distances, plexiglass dividers, wouldn't really be expected to eliminate transmission. However, it could reduce some transmission risk when we're thinking about larger droplet spread, which can still happen with COVID-19. It also happens, more predominantly with things like flu and RSV, which we've really had to contend with this season as well. So there's nothing wrong with having plexiglass dividers. I think the place that I've seen them be the most useful is really at kind of entry points of the facility. So really where kind of your entry staff are greeting people, those folks tend to have a lot of different contacts with a lot of people coming in during the day. It's not a must, but it's something that could be considered. And it's not a requirement to have between residents during dining. It could be something that's used, but I would imagine it'd be a bit tricky to implement. All right, this one's a longer one, but I think it's a similar and important one. This references the guidance specifically in the communal activities during outbreak section. The first sentence references community activities where there is no outbreak and advises that these activities be offered while adhering to core principles of infection prevention and control. This would seem to include physical distancing. So, as I mentioned, physical distancing has really been kind of de-emphasized as a specific element of core principles, although it is in CMS guidance, particularly in relation to visitation still. And I think it's important to keep thinking of it as a tool, as we said, to reduce crowding. This question goes on to ask if plexiglass dividers are required for dining, and same answer there, not required, could be a tool to use if residents are still able to communicate okay with those. I think these strategies, we talk about outbreak scenarios, and it's true, like those are the scenarios where we really want to think carefully about group activities and communal dining. But I think, COVID is one of those pathogens that we always have to be in a preparedness stance for, because it can be introduced in a facility and it can spread quickly. So some of the things we've talked about around reducing risk around dining, maybe just having smaller groups at tables, trying to improve ventilation and dining rooms. Those are good strategies to be implementing, irrespective of an outbreak, but particularly when we're seeing increased spread of some of these respiratory pathogens in the community. So definitely something to think about in advance as well. All right, next question. Are family and visitors allowed to join group activities and dining? And then it references CMS guidance a bit, which says that facilities should limit movement in the facility to the maximum extent possible. For example, visitors should not walk around halls or areas of the facility. Rather, they should go directly to a residence room or designated visitation area. So, from our perspective, in the healthcare associated infection world, we don't really recommend families joining big group dining with other residents, as it does kind of increase that risk of super spreading event. If someone kind of unknowingly brought COVID-19 or even another respiratory pathogen in the building, it's just the potential for a lot of contacts and a lot of unmasked contacts at once, which is just hard to contend with if one of these bugs gets introduced. But eating with a resident in kind of specified visiting areas or in their room is a reasonable thing to do. Of course, it'd be great if folks were up to date on vaccines, but it's not required as a requirement of entry. Yeah, and then I just had some notes here about this being particularly true when we're seeing spread in the community. And just a note that when not eating, visitors should continue to mask while in setting per our mask requirement. Are we still supposed to adhere to 6-foot physical distancing during activities? If yes, does this mean we can't load up our bus and take residents on scenic drives? It does not mean you can't do that. That sounds lovely. But in effort to reduce crowding, should be used whenever possible. So, some things you can do if you are going into scenarios that can be a bit more crowded, like having a bus of folks, would be screening for new symptoms specifically before the activity, just to make sure no one's kind of popped up that morning and has, new symptoms and is not feeling well and could potentially spread to others. masking in that setting, of course. And then, you know, if you're in a car environment, don't have access to portable HEPA filters, simple things like opening the windows a bit and cranking up the heat, that those kind of things can really make a huge difference in bioburden and risk of spread. So just a couple of things to think about there. Jumping into some testing items, looking at the time here. Since our county is no longer in high transmission level, it seems we don't need to routinely test asymptomatic staff who are not up to date with all recommended doses of vaccine. However, it seems we are required to test residents who have been off-site for 24 hours. So it is true that asymptomatic testing of staff, it was not included as a recommendation in the most recent CMS guidance. That's what was released back in September. So that has been dropped. So the facilities, we have had some facilities continue to do it at their own discretion. That is really up to facilities. In terms of resident testing upon readmission, so if they're off-site for 24 or more hours, it is not a requirement, but it is strongly recommended in CDC guidance to avoid introduction in facility to do some admission testing for residents. And the way testing is recommended now, it is serial testing. So that would be upon admission, and if negative, again, 48 hours after the first negative test. And I'm sorry, 48 hours again after the second, if that one is negative. So the reason this is recommended this way is trying to avoid those introduction events into facilities is still really important. When we have spread in our communities, it's just so difficult to avoid kind of bringing it in any scenario. We don't necessarily have quarantine requirements like we used to for admission. So what has sort of replaced that is this serial testing recommendation, and it is a really good best practice to avoid some of that initial spread in a facility. The testing section states that after an exposure, an asymptomatic staff member has no work restrictions unless they can't wear source control. This implies that without exposure, it would be okay if staff didn't wear source control. This is confusing since the masking section clearly saying that 333-019, our masking requirement, remains in effect. It absolutely is a little confusing. I think we wanted to be consistent with CDC wording in there. The masking requirement is indeed in place, although I will note, as I'm sure it's on the top of all of your minds these days, our masking requirement is under discussion right now. So there will likely be some news on the future of that rule fairly soon. But it does mean that you know, source control masking is required kind of irrespective in our healthcare settings. But I think the reason CDC focuses on it this way is those are particularly high stakes moments if someone had an exposure and they're working in the facility. So, it basically means that if there was some issue with the ability to wear source control for that individual, work restrictions would need to be implemented. It's true that the masking requirement remains in place, but think about these scenarios as ones where it's particularly important that those individuals strictly adhere to the requirements and avoid unmasked exposure. So like trying to avoid, you know, unmasked eating with other staff in the facility, and giving some education about the appropriate use of masking, just to make sure those individuals understand how high stakes that scenario is. Next question on table 1. This is the first link put in the chat. Interim summary of long-term care facility infection control policies for COVID-19 and other respiratory pathogens. Indicates that it's recommended to have serial testing for new admissions, clarifying that this is no longer mandatory, reaffirming that this is a strong recommendation for public health. You might get specific recommendations from public health to do this, and we expect folks to follow that, and kind of echoing Jack's comments about, you know, the difference between a recommendation and a requirement and kind of seeing that big picture. But these types of interventions can become really important, and it is still a best practice. All right, outbreak testing. Facilities, this references facilities should continue to use broad-based testing when the facility does not have the experience and resources to perform individual contact tracing. So if we know where the exposure came from and we can affirm it occurred on staff days off and they have not returned to the facility, do we have to do broad-based testing or can we use contact tracing? We are wasting a lot of time and resources on testing staff and residents when exposures are occurring on days off. So in that particular situation, if there truly was not contact in the infectious window, which is the 2 days before symptom onset or the 2 days before test, if asymptomatic, through their isolation period, it would not necessarily need to trigger broad-based testing. I would note, though, that we have experienced many times the situation where staff members have actually had contact with other staff members off-site or have socialized or live with or room with, just to flag that it's a good question to ask as part of a contact tracing effort, just to make sure they did not have outside the building contacts with people that are still working and potentially risk spread. Unfortunately, we have definitely seen that scenario play out. If an individual was on site during their infectious window, so again, the 2 days before their first symptom appeared or their test date, if they're asymptomatic, it should prompt testing. And that could be either contact tracing or broad-based testing. Contact tracing, as we said before, should really be used in scenarios where we're readily able to identify contacts. If the contacts are really difficult to identify, you don't have staff or expertise on site to conduct that contact tracing, or simply if the index case had a ton of exposures in the building or exposures across units, broad-based testing is strongly recommended. It's just honestly hard. We've learned a lot of lessons about contact tracing in this, and it's very hard to catch up with if there's a ton of exposure in the building. And again, public health, local public health or our teams may have specific guidance about the appropriate approach here, and those recommendations should be implemented. After residents leave for 24 hours, do they need to be tested? The guidance says they should be treated as new admissions. So serial testing is recommended, as we've talked about before, and that's a series of 3 tests separated by 48 hours. All right, on to PPE and masking. So first question here, to be clear, facilities are not required to wear N95s during outbreaks unless providing direct care to a resident positive or a suspected COVID-19 case. So during outbreaks, broad use of N95 respirators and eye protection for all staff on affected units is strongly recommended. It is true that it is not a blanket requirement and there can be some nuance here, but I will note that it does protect from those exposures to kind of asymptomatic or pre-symptomatic individuals who are infected but not yet showing symptoms. That can get really hard to stay ahead of. It also addresses issues where the air right outside of a patient room could be contaminated and protects staff that way. So we often, as a team, are recommending kind of broad-based, particularly when we have larger outbreaks or outbreaks in situations where it's hard to close doors or residents have a hard time isolating in their room. So you will see this recommendation coming out of public health. And again, if public health is recommending, it's important to make sure to implement that.
Hey, Becca.
Yeah.
Would you like to answer some questions that have come up based on some of the information you've presented already, or would you like to save those towards the end?
If it's okay with you, I might save to the end. I see a lot of good ones coming in, but we might touch on a couple. So yes, but we will get to all the questions in the chat. Let's see. Source control is recommended for staff and residents with high-risk exposures for 10 days. Is this just a recommended requirement, or do residents wear source control if staff are already required to wear source control at the time? I think the bottom line question here is, if source control means N95 in this instance and a resident cannot tolerate this, do they need to go in quarantine for 10 days after a high risk exposure? So a bit of nuance here. So the last round of CDC updates removed routine resident quarantine after exposure from guidance. So it was no longer kind of a core strategy that we're using. And this was really largely in recognition to the fact that there were a lot of exposures happening often. So there was a lot of kind of quarantine isolation happening with residents. And I think we all know that too much of that can be problematic as well. So what they've done instead, as we've sort of talked about before, when there's an exposure in the building, serial testing is recommended for those that are exposed. And that's something our facilities have had a lot of experience doing. So the source control recommendations, as we talked about above, are always in place because of our masking requirement. So CDC has a bit of language about when quarantine and the use of the PPE that we use when someone is in quarantine, so N95, eye protection gown, and gloves, should be considered after a close contact exposure. And one of the things they recommend is when the patient is unable to wear source control. So there's a bit of discretion here because that is certainly one of the things. We have a lot of residents who struggle to wear masks for a lot of different reasons. So it's not that it necessarily prompts an immediate quarantine for residents that aren't able to wear their masks perfectly every time, but it should be something that's considered. And I think that's particularly true when they have some of these other potential risk factors that can make it more likely that there's going to be spread. So if the resident is moderately or severely immunocompromised, if the resident is residing on a unit with others who are immunocompromised, or if there's just kind of unmitigated, uncontrolled spread on the unit, quarantine can become a really important tool even now. So you may see this recommendation coming from public health, particularly in situations where we're seeing a really severe outbreak or an outbreak that's going on for a long time or has been uncontrolled. Those are the kind of scenarios that we tend to see that. All right. All right, this is a good one. Guidance indicates that residents can be unmasked in their designated room with the door closed. To clarify, if residents want their door opened, they have to have a mask on. Also, our facility is supposed to try to mask residents to and from meals and let them take them off while eating. We're confused by this logic. If they are more likely to contract COVID sitting with a table mate drinking versus simply walking down a hallway. And I think that this is true, right? This is all about kind of incremental risk reduction. You know, masks while eating aren't feasible. We don't want people kind of taking on and off a mask with every bite. But steps to reduce transmission in break rooms and dining area, as we talked about before, should absolutely be implemented because masking isn't possible in these scenarios and they are higher risk. OHA masking requirement does not require residents to mask when they're in the room with the door closed. So if it was a situation where it was open, again, because of that kind of risk of aerosol spread of some of these pathogens, that would be a situation where we'd recommend the resident continue masking. If a resident is genuinely unable to mask, facilities should take steps, like many that we've talked about, to reduce the risk of illness, following those core principles of infection prevention. This is a situation where physical distancing can actually become useful. And ensuring others in the facility are wearing masks as required. All right, vaccines. Let's see, on table 1, interim summary of long-term care infection control and policies. Staff COVID vaccination indicates that long-term care facility staff are required to be fully vaccinated. Our question is why the vaccine doesn't prevent transmission. So COVID-19 vaccination reduces, but it's true, it does not eliminate the risk of transmission of COVID-19. And that's why we use kind of these layered prevention strategies, masking, improving ventilation, getting folks up to date on their vaccines. Fully vaccinated individuals do have lower risk of severe disease or death than unvaccinated individuals. So we still think it's important. Though the rule currently only addresses primary series, I just want to note that OHA strongly recommends, as does CDC, that residents and staff of long-term care facilities be up to date with their COVID-19 and flu vaccinations to prevent the spread of these pathogens. Got to mention flu while I have a minute. to prevent the spread of illness in facilities. And I'll just note here that staff and residents are eligible for a bivalent booster 2 months after completion of their primary series. They can get their flu vaccine at the same time. It's still not too late this season. Just want to put that out there. One thing I would note on the vaccination, we get a lot of questions both ways here. We get a lot of questions about why the rule is still in place, and that's what I just addressed. But we also get questions about why the rule doesn't include booster information, booster requirements. And though we do strongly recommend it, think about this rule as the first step, right? At this point in our country's vaccination strategy, you have to get your primary series before you're getting boosters. This requirement really requires people to take that first step. All right, on to just a couple more here, bear with me. Under what circumstances are we required to place a resident on transmission-based precautions? Is it only when they've tested positive? So transmission-based precautions apply to patients with symptoms of COVID and asymptomatic patients who have met the criteria. So have either tested positive or have had an exposure that does warrant quarantine. Those are some of those considerations we talked about previously. One thing I would note is this year was really complicated, as you all know all too well, because we had other pathogens circulating. We had RSV, we had flu, we had kind of regular seasonal bugs like adenovirus. There is a real challenge in sort of knowing what PPE and what strategies to use when we have lots of bugs. When someone is initially symptomatic though, because COVID-19 strategies are the most conservative, they involve staff wearing an N95 and eye protection, gown and gloves, it's important to kind of assume it's COVID until otherwise demonstrated. So until we have, COVID negative tests or we know what agent is at play here. And just important to keep in mind that we have seen co-infections of COVID and other bugs. So when in doubt, it's important to follow those COVID-19 precautions. And I would just refer to the table that's included in the guidance. It was one of the links we had above. So it really shows kind of what PPE is used when for different bugs and has some additional descriptions about that. All right, one more question about our residents still needing a quarantine period. And as of September 2022, the answer is no, as a general matter. So CDC states that in general, asymptomatic patients no longer require empiric use of transmission-based precautions following close contact with someone with SARS-CoV-2. But we have discussed some of the reasons why someone might want to be placed in quarantine after an exposure, and unable to mask was one, but also, being immunocompromised or being on a unit with others who are immunocompromised. And again, public health may recommend quarantine as a strategy in severe or uncontrolled outbreaks. Last two here, these are pretty short ones. Can we put new admissions in the same room together if there are no other options? New admissions that are not under transmission-based precautions can be placed in shared rooms with other residents. If all other options have been exhausted. But I would note that in these situations where people are rooming together and they sort of have an unknown COVID status because there may have been out of facility exposures, admission testing is particularly critical to make sure there's not spread. Last question. I have questions about PPE and infection control in my facility. Where can I direct these questions? So a few things, Jack mentioned, the door is open on the APD end, and the same is true of our HAI program. We tend to work on the more, how do we implement these different strategies? And so I'm going to ask Bailey to put in the chat a link to request our help anytime you need it. So if you need any kind of consultation, this can be fairly formal or just a call if you want to run something by us. We are always open to that and happy to help talk you through anything that you're trying to put into place or have questions about. I do want to note, because this is a big group of our long-term care facility partners, that we do currently have a program right now that's prepping new infection control specialists and infection prevention staff to to prepare for the CIC infection control certification exam. We have study sessions and office hours happening weekly with our infection prevention team. They've been going really well and they've been really well received. So part of this includes getting a whole bunch of infection control resources, memberships, textbooks, which can really help get our IPs up to speed on some of this, especially if you have some newer staff. So I just want to put that out there, and Bailey can put that link in the chat as well. So with that, I'm going to stop there and maybe defer to you, Bailey, to help me answer some of the chat questions.
Yeah, sorry about that. One of the links for the registration isn't working, so I will be sure to update that in the chat. So working more towards the top, Becca, any idea or rough idea of when a masking update for the rule would be provided to this group? And specifically quantify what soon means. Is it a month? Is it a quarter?
Yeah, I don't have a specific date on that. It is under discussion now, so I won't try and predict an exact day, but I will say the intention is to announce something as soon as possible.
Great, thank you. Working our way down, you have touched some of these. So staff routinely have 2 consecutive days off a week. Since we have no need to test staff for being out of the building for 48+ hours and arguably going more places and doing more activities likely to expose them that an average resident might, what epidemiological evidence is there to warrant testing residents who have been out of the building for 24+ hours?
Yeah, so I think it's a good question. I think there are a few things there. So we do often have challenges identifying symptoms in residents. COVID-19, as well as some of our other respiratory pathogens, can present in a lot of different ways. So I think doing that testing, if there's potentially been some community exposure, can be really important to make sure we're catching COVID early. I will say it's also a bit more controlled when we have staff. Our staff are wearing masks and they understand, you know, hand hygiene and infection control. We have a lot of residents who do that really well too, but it can also be a challenge. So I think capturing it in a population that could readily spread to others is still really important, especially when they have roommates and things like that. That's just a really tough scenario to prevent spread. So the sooner we know, the better. I would also say for residents that catching an early infection is super important because it gives us the capacity to treat it. And that's true of flu, it's true of COVID as well. So I think there's some solid evidence that we can protect residents and prevent some spread if admission testing is being done. And same goes for just early testing of symptoms and testing residents when there's been an exposure in the building too. I mean, those are all important scenarios, and we want to make sure that resident infections are being identified.
Thank you. Are rapid tests acceptable at this point, or are PCRs required?
Yeah, so rapid tests are accessible, and it's one of the reasons you're seeing this kind of reference to serial testing and CDC guidance, because we know that there are some sensitivity issues, so ability of the test to pick up, especially early or asymptomatic COVID infection with the antigen tests. Serial testing seems to do much better and increase the likelihood that we will catch an infection if it's there. I will say that we do sometimes in public health recommend PCR testing in some situations. And I think the larger outbreaks where there's lots of potential exposure happening in the building or unmitigated spread. So when we see these we have had outbreaks that have just gone on and on and on, and they're really difficult to manage on your side, on our side, everywhere. So those are situations where we might recommend stepping up to a PCR test because it can help capture. It's just a bit more sensitive, right? So you're going to capture and be able to put people in appropriate isolation and get them on work restrictions a bit sooner.
Thanks. Can we clarify the incubation period for COVID? You had said that just the 2 days before symptoms or positive test. This person says, I believe it is 2 to 14 days before symptoms or positive test.
Yeah, great question. So two concepts here. One is the incubation period. So the time from when you're exposed to a bug to when you start developing symptoms. It is true that is still 2 to 14 days. We saw a little bit of a shortening of that with some of the Omicron variants. So most infections, if they're going to present within 10 days. But we still do reference that 2 to 14 days because that does tend to be the broader range, even if that kind of tail end tends to be a little rarer these days. Separately though, for people that are infected, there is something we call an infectious window, which is the period where they are most at risk to spread to other people. And that's the period we tend to think less about the incubation period, more about the infectious window when we think about contact tracing. Because we really want to think about, for that individual, when was the window where they were most likely to have spread to other staff in the building, other residents. So we really look at that 2 days before the first symptom presented, or the first 2 days before positive test if they're completely asymptomatic, and then through their isolation period, which for most people ends when they've recovered and they're 10 days post symptom onset. So that's the entirety of an infectious window, and that's the period that helps guide you when you're doing contact tracing. That's what helps you ask about relevant exposures.
Thank you. In CDC's update in late September, they specifically called out assisted living facilities as not being healthcare settings. OHA has said that in Oregon, they still are. When will we see this change? They are by design supposed to be home-like settings. Currently, we are still quite medicalized. Assisted living facilities are supposed to be independent living plus. When can we go back to being that instead of the current status, which is essentially a SNF or skilled nursing facility?
Yeah, thanks. So we do try and be fairly consistent, at least with infection control expectations across nursing facilities, assisted living facilities, and residential care facilities. And that's simply because we've seen a lot of spread in all of those settings, nursing facilities, residential care, assisted living, and especially our memory care facilities. It's been a challenge, as we all know. So the basics of infection control, being able to isolate, maybe even cohort if the facility layout and kind of room situation allows, using hand hygiene, doing environmental disinfection, masking for right now, those interventions are still going to be really important, and we still think they're really important to prevent spread and to keep everyone safe in these settings. I will say that on our end, and I know this is true for APD as well, the home-like environment is something that we want to help you protect too. It's super important. And I think when we try and work with you on how to implement some of these things, how to create isolation policies for residents that are infected, we really want to do it with that in mind. So we're really going to try and meet you where you're at and have a conversation about how we can best implement these things in a way that maximizes quality of life for residents. And I will say that one thing we really did, and this was because of really great questions and I think ideas that came from you all, what we put in the guidance about communal dining was really intended to be a bit of a response to this, right? Because it's true, when there's a raging COVID-19 outbreak in a facility, we're gonna recommend that communal activities be halted for a little while so we can get things under control. But we know there are some settings that if that went on for too long, or particular residents weren't able to get out and exercise, that could really be a serious quality of life issue. So that's why we added some considerations for if you are putting back into place some of these communal activities before an outbreak has ended, that could be reasonable, but here's some strategies to reduce risk around those. And we've seen facilities do this really successfully. So it's just kind of thinking about the basic infection control in all of these kind of day-to-day activities that becomes really important. So I will say that it's a big focus on our end as well to strike that balance between quality of life and the infection prevention. But we've seen our assisted living facility and residential care facilities do some really incredible things and implement some pretty amazing infection control strategies. So we know the capabilities there. We're just here to support, to again, kind of strike that balance.
How How soon, and I'll go ahead and put the CDC's link for the healthcare personnel work restriction link, but how soon can staff return to work?
Yeah, so CDC has some nice guidance to summarize this, and Bailey's going to put that one in the chat, it sounds like. So I will say that this is where there's some nuance, right? Because it really depends on what the staffing situation is. And I know we're seeing a little bit of ease of some of the staffing crisis scenarios we've seen. So we've really been seeing facilities kind of step out of that crisis staffing scenario and back into more kind of conventional or contingency strategies. So I will say that the standard is 10 days. CDC does have a conventional strategy, so just kind of a baseline one that would allow infected staff to return to work at day 7 if they have a negative test between day 5 and 7, and that could be an antigen test. That is an option, and we see facilities doing that sometimes. I think that sometimes getting someone in for a test or making sure they get that test can be a little tricky, so we see facilities erring on the 10 days. There are some kind of higher level escalation strategies when there are staffing crises in the building that involve staff coming back at 5 days, or even in the most dire of circumstances, not having any isolation period at all if they're well enough and willing to work. I will say those latter items are really ones that should be reserved for situations where there are no other options. You have tried everything. You have asked for staffing assistance. You've kind of exhausted all your options, because depending on which one you're doing, there is going to be risk of spread, particularly in the scenario where staff are just not having any work restriction at all after testing positive. So I really recommend, if you're using those latter strategies, please make sure you're reaching out both to your local public health authority as well as to your OPA, and just have the conversation to make sure you're exhausting all your options, because that really is kind of one of those situations where there's a bit of a balance, right? Because you're addressing a staffing situation, but then there can be ongoing spread in the building if you have staff that are infectious around other staff, and it can really perpetuate some of those issues. So we really try and push you toward those more conventional strategies as much as we can. And note that there are different work restrictions periods, because why not have things be a bit confusing for some of the other pathogens? So one of the reasons we made the table that's included in the guidance that summarizes this is it does just give you an at a glance look at what work restriction looks like, or what resident isolation times should look like for these different pathogens. It tends to be a little shorter with flu and RSV.
Just to clarify, when not in an outbreak situation, if a resident is in a private room, they should wear a mask if the door is open. By the way, usually they will not, despite encouragement.
Yeah, I think to the extent that they're able to tolerate it, it's not a bad idea. It's not, of all the scenarios, it's maybe not the biggest one to focus on. I think the ones that we tend to really look for and try and remediate in facilities are ones where residents are around other residents or staff members, because those are kind of close contact scenarios. I do think it could be potentially important if we're in a roommate situation, but otherwise we really tend to focus on close contact type exposures, communal activities, situations where there's some crowding.
Okay, sorry, just scrolling through more comments versus questions. So we have staff abusing the rule about not being punitive for call outs for COVID symptoms now that we have rapid tests. Is the non-punitive symptom rule still in effect?
I might need to phone a friend on that one. Not exactly sure what that's referring to.
I'm not sure if that's something Jack would know.
I'm not sure exactly what's being referred to there either. Whoever is asking that question, if we can get a little more, perhaps a reference to the rule that you're looking at, or something we can either do a better job of answering, or I can get some information out, but I'm not quite sure either.
All right. So Ryan, either you can go ahead and email us or put it in the chat. I'm going to keep scrolling through. Any chance you'll send out a bulleted point set of current recommendations, not requirements, not just recommendations, please?
No immediate plans to add to our current guidance. That really was what we intended to do with it. We wanted to kind of pull everything together, so it was a bit more at a glance and not so kind of clicking around different CDC guidance documents and CMS documents. We will update that as things change. For example, when the masking requirements changes are announced, we'll put that in this guidance. So we will keep it up to date for you. I think we can commit to that. Bailey and I are also happy to have these office hours more regularly. It's really nice to see this many folks joining us on a snowy Friday. So that is also something we could continue to do. But I don't think there's an intention to kind of bullet point it more than it is. I think it was tough for us to get it down to this level of this short of a document. To be honest, it's really hard not to get kind of wordy when we put these together. But we're gonna stick to the current format for now.
Great, thanks, Becca. And just one of the ones that stuck out to me is from Margot, and I'm sorry, Margot, I'm not seeing your last name on the comment, is how can I get on your mailing list for the guidance update? I received this link by a forwarded email. So that's a great question. Guidance to you all has historically been forwarded via provider alert. And it's also posted on the ODHS website. And Becca, I'm not sure if it's still something that's reflected on the healthcare provider resources on the OHA website. But so signing up for the provider alerts would be a good start. For if Becca and I do hope to start hosting these forums more regularly, and those invitations would likely still go out at least by a provider alert, but can also be forwarded via industry partners like Leading Age and OCA as well. So if you haven't signed up for a provider alert, this would be my encouragement to do so.
It looks like Nicolette just put the link in the chat. Thanks, Nicolette.
Thanks, Nicolette. So this is back to that punitive rule. We were told many moons ago that if a staff member called out due to having COVID symptoms, we could not ask them to excuse the absence or proof of illness.
Well, I will say that non-punitive leave approaches are still important, given that we're contending with respiratory pathogens. I do think there's more guidance that CDC has put into, how do you interpret a test? What do you do if someone can't get tested? And I think that can help a little bit with developing some of those policies. I'm happy to kind of chat offline about that a little more. It's an interesting question, but I don't have much beyond that. There's definitely a balance, right? We need enough staff to staff our building safely. And at the same time, when someone tells you they're sick with respiratory symptoms, we don't really want them around vulnerable residents. So that's a little bit difficult, but happy to help troubleshoot that a bit offline.
Okay, and that puts us at 158, and I want to be cognizant of everyone's time. Becca or Jack, did you have any kind of closing words before we end the meeting?
I don't have anything to add. Just want to reiterate again, at any time for any question, there's no question too small. I think all of us, both SOQ and Bailey and Dr. Pierce, are more than happy to help with interpretation or answering questions. So I look forward to hearing from people.
Yeah, same, ditto. Thanks for being here. Thanks for listening and sending in so many good, well thought out questions. Where we continue to be here if you need us.
All right. Thank you, everyone. In the chat, I'm going to put another resource for you all. So for those questions regarding, the questions that would typically go to your OPA or surveyor, please continue to send those on to Jack's team, as well as Becca's team for the more technical aspects of the infection control. But in the chat, if you're all able to see it, I'll be putting the APD population health team email as well, that feel free to send questions on, and we do work closely both with Jack's team and Becca's team, so happy to provide any resources that way as well. And thanks again, everyone, for joining. We appreciate your time.